So I would like to introduce Professor Kuo Hu Chen. Professor Kuo is a professor in the School of Medicine, Tzuchi University, Taiwan, and the director of the Department of Obstetrics and Gynecology, Taipei Tzuchi General Hospital, Taiwan. After graduating medical school from the National Yang-Ming University, Taiwan, he obtained his PhD in public health from the National Taiwan University, Taiwan. A staunch advocate of minimally invasive surgery, he is the director of the Taiwan Association of Gynecology and supervisor of Taiwan Association for Minimally Invasive Gynecology. He is adept at laparoendoscopic single-site surgery, LESS, and Da Vinci robotic surgery. His many accolades include excellent research of Asia Pacific Association for Gynecology Endoscopy, APAGE, and excellent research of Taiwan Association for Minimally Invasive Gynecology, TAMIG, among others. So without further ado, can we proceed with the presentation by the Professor Kuo, the recorded? Thank you.
Dear colleagues of GESM, Dear colleagues of GESM, I'm Dr. Kuo Hu Chen. It's my pleasure for being here to give a short speech for the topic of minimally invasive surgery. Today, I would like to discuss laparoscopic cystectomy and oophorectomy of benign in pregnant and non-pregnant women. Laparoscopic ovarian surgery in non-pregnant women. There's some important notes to be discussed. First, tumor with higher morbidity or poor location. In this situation, you may consider a suspension technique, such as OSAS, OSAS. Second, tumor with unassured contents. In this situation, you should use a laparoscopic endo bag, and this can be replaced with a surgical glove. Third, tumor with pelvic adhesion, for example, endometrioma. In this condition, you can expose and identify the ureter, or you can remove the adhesion and let the cyst to avoid ureter surgery. Fourth, in COVID-19 positive patients, wearing protection clothing against the virus is an important issue. First, tumor with higher morbidity or poor location. You may consider the suspension technique, ovarian suspension with adjustable sutures, OSAS, OSAS. We have published the technique of OSAS in a journal of minimally invasive gynecology several years ago. You may use a 2-0 proring with a straight needle to do the OSAS technique. It's quite easy using a 2-0 proring straight needle. A. The surgeon palpates the abdominal skin overlying the tumor to determine the appropriate site for needle insertion and the ovarian suspension. B. One of the straight needles enters the pelvic cavity through the abdominal skin and into the peritoneal cavity, like this. C. After penetrating the ovarian cortex, the straight needle is pulled outside the abdominal skin. D. After cutting off the double ends needles, the double sides of the remaining suture are held together by a clamp without knotting the stitches. And the ovarian tumor with higher morbidity or poor location is now fixed onto the anterior abdominal wall to facilitate the surgery. F. The surgeon or assistant could lift, loosen, or fix the stitches to adjust the tension of the suspension on demand. So the tension is adjustable. Now an oophorectomy can be done easy. As you can see in the figure, we are doing a oophorectomy by the OSAS technique. 2. Tumor with unassured contents. In this condition, you can use a commercial endo bag to prevent from tumor spillage, or you can use a surgical globe serving as the laparoscopic endo bag. Third, tumor with pelvic adhesion, for example, endometrioma. In this situation, you may dispose and identify the ureter, or you can remove the pelvic adhesion and land the cyst to avoid ureter injury. This can be done by retracting the ovary upward to avoid ureter injury. Fourth, in COVID-19 positive patients, wearing protection clothing against the virus is an important issue. In a negative pressure operating room, I will recommend double layer protection. The first layer, protection clothing is worn outside the operating room, like the figures showing here. And the second layer protection clothing is worn inside the operating room. Laparoscopic ovarian surgery in pregnant women. Doing laparoscopic ovarian surgeries in pregnant women is more complicated than that in non-pregnant women. You have to consider these issues. First, the safety of laparoscopic surgery in pregnancy. Second, if you are going to perform an oophorectomy, you have to consider the effect of hormone on maintaining the pregnancy. Third, you cannot use the uterine manipulator during pregnancy. 1. Incidence. Persistent masses are most common functional cysts with very low rates of malignancy, which are reported at 2% to 6%. The incidence of acute non-obstetric abdominal surgical emergencies in pregnancy is low. Also, the absolute numbers of ported and hemorrhagic ovarian cysts are low in pregnancy. This report is from your hospital, Putrajaya, Malaysia. So this is a Malaysian study enrolling 115 patients to examine the histopathological type of ovarian cyst during pregnancy after doing the surgery. As you can see in the figure, the leading cause of ovarian cysts during pregnancy is endometriotic cyst, 28%, followed by mature cystic teratoma, 24%, and serous cystadenoma, 23%. 2. Principle. Observation is accessible for all other cystic lesions, provided ultrasound is not concerning for malignancy and the tumor markers are normal. Initial observation is warranted for most cystic lesions less than 6 cm in size. However, pregnancy should not be a reason to delay urgent surgery. In some conditions, such as adnexia torsion, tumor rupture with internal bleeding, and laparoscopy is a safe and effective treatment in grave patients with symptomatic ovarian cystic masses. Surgery. Laparoscopic surgery is associated with faster recovery, shorter hospital stay, and a trend to lower rate of wound infection for pregnant women. Clinicians should be aware that there is increased risk of bleeding due to increased vascularity of uterus and anasa, but this risk is currently not quantified. Risk. Modern anesthetic agents, muscle relaxant, and opioid are not thought to be teratogenic when used in therapeutic clinical doses. There is no additional risk of fetal malformation or stillbirth in women who undergo non-obstetric surgery compared with pregnant women who do not undergo surgery. However, the maternal condition necessitating surgery may be associated with risk of miscarriage and preterm labor. Any surgery in pregnancy is associated with maternal and fetal risks. Therefore, non-urgent surgery should be postponed until after pregnancy. Timing. If possible, laparoscopic surgery will usually be arranged in the second trimester because the placenta will almost replace the ovaries to function as an endocrine provider to secrete estrogen and progesterone after 12 weeks gestation. And this is especially true in pregnant cases who have to undergo oophorectomy for inevitable conditions. For example, delayed ovarian torsion, since an earlier intervention may induce hormone deficiency miscarriage. If possible, avoid oophorectomy in a small gestational age. Timing. The recommendation for non-emergency procedures during pregnancy has to be avoid surgery during the first and the third trimesters to minimize the risk of spontaneous abortion and preterm labor. However, laparoscopy can be performed during any trimester of pregnancy when operation is indicated. Recent small series have shown good maternal and fetal outcomes for laparoscopic anasa surgery up to 34 weeks gestation, which extend historical recommendation to limit laparoscopic surgery to the second trimester. CO2 insufficient and fragile. Upward displacement of the diaphragm by pneumoperitoneum is more worrisome in a pregnant patient with existing restrictive pulmonary physiology. Some has recommended intra-abdominal insufficient pressures be maintained at less than 12 mmHg to avoid worsening pulmonary physiology in gravid women. Creation, the pneumoperitoneum should be gradual, as should alterations in maternal positioning. CO2 insufficient and pressure. If you still have concerns about the safety of CO2 insufficient on the fetus, you may consider a gasless laparoscopic surgery. Clinicians should be aware that in experienced hands, direct gasless entry may be an alternative, but there is insufficient information in late practice to suggest this as a routine approach. As you can see in the figure, we use a retractor to lift the abdominal wall upward to make a space for the laparoscopic instrument to operate within the peritoneal cavity. CO2 insufficient and pressure. If there is difficulty in performing a gasless laparoscopic surgery, for example, the ovary may be obscured by the enlarged uterus or in performing general laparoscopic surgery. Because the uterine manipulator cannot be used during pregnancy. You may consider sling suspension OSAS or SAS again to expose or fix the ovary to facilitate the minimally invasive surgery. Selection of port location. The location of the primary port will depend on the level of the uterine fundus. The uterine size should be determined by palpation or ultrasound. Clinicians should choose their primary port location, including umbilical, supraumbilical, subxiphoid, and palmar pond, which is located at left upper quadrant in the middle clavicular line. According to uterine size, location of pathology, and the operator experience. As you can see in the figure, the uterus is enlarged in an advanced pregnancy. So the focal side for port insertion should be made upward to make space for the laparoscope and the instrument to enter into the pelvic cavity. After laparoscopic surgery, fetal heart monitoring of the fetus considered viable should occur preoperatively and postoperatively in the setting of urgent abdominal surgery during pregnancy. Likewise, fetal ultrasounds may be done before and after surgery to confirm the fetal well-being and reassure the mother. Fetal ultrasound and fetal heart monitoring. So I will make a summary for laparoscopic ovarian surgery in pregnant women. First, women with asymptomatic simple cyst may be managed conservatively in pregnancy, provided that symptoms are absent or acceptable to the woman. Second, women with large, non-torted symptomatic cysts who wish to avoid surgery may be offered aspiration under ultrasound guidance during pregnancy, with definite cystectomy after delivery if required. However, pregnancy should not be a reason to delay urgent surgery in some conditions such as a nasal torsion, tumor rupture with internal bleeding. Third, laparoscopy is a safe and effective treatment in gravid patients with symptomatic ovarian cystic masses. With care and patience, you can do the minimally invasive surgery better. Thank you for listening. Dear colleagues of GE.
Okay, Professor Ko, can you see me? I can see. Where is? Okay. Professor, can I wave you on? Can you wave you on? Okay, yeah, already in. Okay. So, thank you, Professor, for your recorded presentation. It's very informative. So, we have a few questions from the participants. Okay. The first question is, do we need to suture the ovarian tissue after laparoscopic cystectomy, like how we do in laparotomy cystectomy? You need to repeat the question, Professor? Okay, can you unmute? Yes. Oh. Hello, Prof. We cannot hear your voice. Can you unmute? Hello.
Hello.
Okay, now I can hear your voice.
I think
Thank you, Professor.
usually, thank you, Chairman and everyone here.
Yes.
Usually we do a laparoscopic surgery during pregnancy, unless this is difficult for the surgeon or for the condition in the pregnancy, because laparoscopic surgery is usually safe in the pregnancy, and the recovery is usually faster. So usually we do a laparoscopic surgery instead of laparotomy in the pregnancy.
So that's mean.
And the pressure we use is usually less than 12 millimercury. And it is proven to be safe during the pregnancy. It's like, okay.
Okay, it's okay, Prof. So the second question is, what is the maximum gravid uterus size of a pregnant woman to be suitable for laparoscopic surgery?
Pardon me?
What is the maximum gravid uterus size of a pregnant woman to be suitable for laparoscopic surgery? The question is, how big the pregnant uterus suitable for laparoscopic surgery, the maximum gravid uterus?
The total size for doing the laparoscopic surgery in pregnancy usually depend on the gestation of the pregnancy, the gestational week of the pregnancy. So it usually the total size usually makes a little bit higher when there is a larger gravid uterus in a larger gestation. I think so.
So, in your experience, how many gestational week you have done, Prof? Your personal
in my experience, the largest week gestation is about 32 to 33 weeks, I guess. So I remember the post-operative course is smooth, and the pregnant the pregnancy is going into term.
Okay, thank you, Prof. So the third question is, where is the recommended primary port placement for patient in third trimester?
Pardon me?
So,
what is appropriate?
The question is port placement for patient in third trimester.
Usually the laparoscopic surgery during pregnancy is performed during the second trimester, because in the trimester the pregnant placenta will almost replace the function of the ovary to serve as endocrine.
organ in the pregnancy. So usually we do the surgery during the second trimester. However, if in case of urgent or emergency surgery, the laparoscopic surgery should not be delayed anymore, because the benefit of doing the surgery outweighs the risk of mother and the fetus.
Okay, so thank you, Prof. The last question. In pregnant patient with uterus more than 20 weeks, what is the recommended position of patient? As we know, supine position or even deep translunar position will cause iodocaval compression. So, pregnant patient with uterus more than 20 weeks, what is the recommended position of patient?
Usually, in a larger week, we will do the surgery in supine position, because of the large uterus during the surgery, and to avoid the compression effect of the large gravid uterus to compress the to affect the cardiopulmonary function during the pregnancy. So we will do the surgery in a supine position. That's our experience. Thank you.
Okay, thank you very much, Prof, for your answer. I hope
Thank you very much.
the answer, all the question has been answered. Okay.
Yeah. Thank you, Chairman,
thank
and
you.
everyone. And I wish some of you can join the annual conference of APH taking place in Taipei in October this year. Thank you, everyone.
Thank you very much.
Thank you.